A very good morning, respected Swankar sir, Chairman sir, Dr. Sajdeva ji, VC sir, Pro VC sir, Dr. Malhotra sir, and all respected seniors and my dear students, colleagues. Today we are going to present a series of few cases from Department of Dermatology as they have similar clinical picture, and one case will be describing in detail. So I would ask Dr. Pearl Dogra, our third year resident, to present the main case.
Good morning, respected teachers, seniors, and my dear colleagues. Today's CCR is about an 18-year-old male with rash, blisters, and extensive peeling of the skin. Today we are going to discuss about this 18-year-old boy who presented to us with multiple painful, itchy, fluid-filled lesions since the last 7 days. He had the history of throat pain with fever since the last 10 days, for which he took treatment. Here in these pictures, we can appreciate the presence of fluid-filled lesions and the detachment of the skin. So the patient was asymptomatic 10 days back when he developed throat pain and fever. 2 days after this episode, he took diclofenac and azithromycin from the local pharmacy. 6 hours after the intake of the drug, he developed swelling over the lips and a rash, which was red in color. The condition got worsened in 24 hours and the patient went to the nearby hospital where antibiotics and symptomatic treatment was given to the patient. His condition got progressively worsened and then he was referred to Dhamnani Medical College for further evaluation and management. When he presented to the department, we took proper history and inquired about the rash and burning sensation on sun exposure. We inquired about the joint pain and the recurrent oral ulceration as history, any history of similar episode in past or the lesions over frictional or trauma-prone site. We asked about the history of any topical application, the history of weight loss, loss of appetite, or we asked about the history of any thermal injury or insect bite. The past medical history, personal history, family history and allergy history in this patient were non-significant. On physical examination, the patient was conscious, well oriented to time, place, person, but had fever, so he was febrile and had tachycardia. The systemic examination of the patient revealed no abnormality. I would now like to ask the audience if they can identify the lesions present in this patient. So here, can anybody be the volunteer? So there are multiple clear fluid-filled vesicobullous lesions present. So here we can see that there are multiple bullas and vesicles present here over the forearm. So it was present all over the body. We can also appreciate the detachment of the skin. Here we can see the detachment of the skin with impending peeling. The peeling has not yet occurred. There is only the detachment which can be seen in this patient over the trunk. And also we can see multiple discrete to confluent dusky erythematous macular lesion which is present over the forearm and the hand in this case. On mucous membrane examination, we could see multiple erosive lesions which were present over the lips and the perioral region with adherent black colored hemorrhagic crusting. So here we can appreciate the adherent black colored hemorrhagic crustings. Similar crusted lesions are also present over the ears. We can also appreciate the sticky yellow colored discharge which is coming out of the eyes, which is the conjunctival discharge in over bilateral eyes, and the peeling of skin can be sheets in the form of sheets can be seen over the neck and multiple areas of the face. On palpation, the bullous lesions were flaccid and Nikolsky sign is positive. So the Nikolsky sign is when we apply lateral pressure to the border of the intact blister and it causes the dislodgement of the normal epidermis and then there is the extension of the blister. So to summarize the case, the patient had sore throat, throat pain and fever. And he took diclofenac and azithromycin 6 hours, after which he noticed swelling over the lips and rash. The condition got progressively worsened and the patient developed multiple fluid-filled blisters and peeling of skin in sheets. On day 7 of illness, he was brought to MGMC. Now I would now like
You have used 3 terms, bulla, blister and vesicle. So for the non-dermatologists in the audience, can you please explain the difference between these?
Yes, sir. Sir, basically, when a patient comes to us, he will tell us that he is presenting with a blister. It is a non-dermatological term. Bulla and vesicle. Now we have to differentiate between these two. So these are, both of them are well circumscribed and fluid filled. Now the bulla is more than 1 centimeter in diameter, whereas the vesicle is a small lesion. It's less than 1 centimeter. That is the main difference between the two. It can contain clear fluid, serous fluid, or serosanguinous fluid, or hemorrhagic fluid that can be present. I would now like to ask the audience for the differentials that we need to consider when such a patient presents to you with such complaints. So the differential diagnosis of such a presentation can be broadly divided into 3 categories: the infective cause, the immune-mediated cause, and the drug-induced cause. The first one is the infective cause. The infective cause includes the staphylococcal scarlet skin syndrome and disseminated herpes infection. Now, the first one is the staphylococcal scarlet skin syndrome. The points against this, condition, is the age. In this case, the patient is usually a child or infant, usually. And the morphology of the lesion, there is a superficial epidermal peeling present in staphylococcal scarlet skin syndrome, whereas there is dusky erythematous lesion which was seen in our case. The mucosa involved. Here, because in the staphylococcal scarlet skin syndrome, the mucosa is usually spared, which is the most important differentiating point between these two conditions. In our case, the mucosa was involved, thereby ruling it out as the differential. The next differential is the disseminated herpes infection. So as the patient was immunocompetent and peeling was present, which will be absent in disseminated herpes infection, we can rule this out. The immune-mediated cause, which includes pemphigus vulgaris and bullous pemphigoid being the first ones. The points against is the onset. So basically in our case, the onset was very acute, whereas in both these conditions it will have an insidious onset. And the morphology. In pemphigus vulgaris, the lesions will be very flaccid, as we can appreciate in this picture that they are very flaccid lesions. Whereas in bullous pemphigoid, the lesions will be very tense. The next condition which can mimic our case was paraneoplastic pemphigus. So the points against this was the age of the patient. This usually occurs in the older age group. And we can also clinically rule this out as there was no history of weight loss or loss of appetite in our patient. Then the next two are the acute cutaneous lupus erythematosus and bullous lupus erythematosus. Both these conditions will have the history of photosensitivity, recurrent oral ulceration and joint pain, which was absent in our case. And also the typical morphology of the lesion being the dusky erythematous lesion, which is very unlikely in these two cases. The next diagnosis is epidermolysis bullosa acquisita. The points against is the age of the patient and the sites that are involved. Here the age will be elderly, older age group. This will present in older age group, and the sites will be the frictional or the trauma prone sites. In our case, the lesions are more generalized. Now the next category is the drug-induced cause. The first one is the bullous fixed drug eruption. Now here we can see the typical morphology of this lesion is very localized and well circumscribed erythematous lesion with hyperpigmented hue, and sometimes there can be a vesicle which can be present in the center. So there will also be the history of recurrence of such lesion after the intake of drug. Every now and then when the patient will take this, they will have the eruption of such lesion over the same site, which was absent in our case. So now we are left with these three differential of the same spectrum. These are the continuum of the same disease, namely the Stevens-Johnson syndrome, SJS10 overlap and the toxic epidermal necrolysis. The only difference between these three is the epidermal detachment. In SJS it is less than 10%, 10 to 30% epidermal detachment is seen in SJS10 overlap, and in 10 it is more than 30%. Now in our case, because more than 90% of the body surface area was involved, the clinical diagnosis becomes toxic epidermal necrolysis secondary to diclofenac.
Why diclofenac alone? Why not azithromycin?
Sir, actually, you look at the culprit drug by a score called the Alden score. So sir, according to that, the lesions, we basically give more weightage to the drug who have been reported in the previous case reports as being a strong indicator, like a strong drug which can cause such a lesion. So the score for both these drugs, for azithromycin it was 3, and for diclofenac it was 5. So our most probable culprit drug was diclofenac. But we asked the patient to stop all the drugs which were previously taken, and we admitted the patient in the ICU and counseled the relatives regarding the grave condition of this patient and the cause of this disease. Zank smear was done, in which no cells of diagnostic significance were seen. The routine blood investigations were sent, and the skin biopsy from the affected sites were done. So Zank smear is a tool for cytodiagnosis. So in this, when there is a bullous lesion that is present, we make a nick, and then we scrap out the lesion from the base of the lesion. We scrap out the material, and then we stain it with Giemsa stain, and we look for the cells. Now, this is a rapid diagnostic tool for various immunobullous disorders, infective etiologies, xenodermatosis, and cutaneous tumors. So here, there were no cells of diagnostic significance that were seen. Upon admission of the patient, the routine investigations along with the ANA titer (ABG) was done, in which the blood urea nitrogen and the C-reactive protein values were high, and the bicarbonate level was on the lower side on ABG. And then the score 10 was calculated. Now what is this score 10? Score 10 is a validated predictor of mortality in patients with TEN. This score is given by giving 1 point for each of these 7 clinical variables, namely the age, presence of tachycardia, presence of malignancy, epidermal detachment, serum urea nitrogen, serum bicarbonate level, and blood glucose level. Now, in our case, the score 10 came out to be 4. So what is this interpretation? This is the probability of mortality which was predicted by this score. So in our case, as the score 10 was 4, the predicted mortality rate was around 62%, which was very high in our case. Now, thank you. Now I would like to invite Dr. Shikha Goyal ma'am from the Department of Pathology to continue.
Good morning, respected teachers and colleagues. I am Dr. Shikha Goyal. I will be presenting the pathological aspect of the case. So we received a 3 mm punch biopsy in our department. The biopsy is processed and the slides were prepared. This is a microscopic examination of the slide, H&E stain section. So here, as we can see, that this is an epidermis and this is a dermis, and there is a split between the epidermis and dermis, leading to a subepidermal bulla formation. This is a high power view of the same section. Here, as we can see, that this is the epidermis and this is the dermis, and this full thickness epidermal necrosis we can appreciate, and in the dermis mild epidermal inflammation is seen. So on the basis of these findings and the clinical presentation of patient involving more than 90% of the body surface area in mucosal involvement, findings were consistent with toxic epidermal necrolysis. Thank you. Now I would like to call Dr. Pearl.
So the final diagnosis of the patient was toxic epidermal necrolysis secondary to diclofenac. The management of such a condition is a multifaceted approach. It revolves around 2 arms. One is the specific management and then the supportive management. We started the patient on injection dexamethasone IV 8 mg twice daily. On day 3, because the lesions were continuing to appear, there were new lesions, we had to add capsule cyclosporin 200 mg in the morning and 100 mg in the evening. We did paraffin gauze and collagen sheet dressing for wound care. We kept the patient in a burn cage. The saline compress and lubricant application was done to soften the lip crust, as it could be a nidus. The hemorrhagic crusting could be a nidus for infection. Ophthalmology opinion was taken and lubricants were prescribed in view of conjunctival congestion, and the further plan was done to consider plasmapheresis if it was required. As the patient already had extensive skin involvement, more than 90% body surface area was involved, the patient was in a grave condition, so we had to plan for plasmapheresis because we were skeptical about these drugs working on the patient. The patient was in improving, but also on day 3rd we could see some new lesions. That's why we were considering plasmapheresis in this patient. And the patient also presented to us very late, 7 days after the illness. So other treatments which could be given were out of question. Then plasmapheresis was the only line which we could think about.
What is the mechanism of action of plasmapheresis in this patient?
Yes, sir. So the plasmapheresis, basically it removes all the cytokines and all the drug toxins that are present. So it will remove that, and then it can show some results. And there are various studies in which it has proven to be efficacious in patients with TEN. Now here we can appreciate the extensive peeling of the skin and sheath. The underlying erythema can be appreciated. Thank you. I would now like to call upon. Yes.
Any role of IVIG?
Yes, sir. Sir, IVIG usually is the second line for such patients. But as our patient presented to us after 7 days of illness, usually the role of IVIG is limited to 3 days. For great results that we see, usually it's in 3 days we have to start the treatment with IVIG. But here the patient came to us very late. So now our only option that was left with us was plasma. Thank you everybody. Now I would like to call upon Dr. Gupta sir from critical care team to discuss the management of the patient in ICU.
So now this patient was shifted to the ICU as Dr. Pearl already told. The score 10 score was more than 4. The risk of mortality in these patients are approximately 62%. So this patient was shifted to ICU, considering that the further the disease will progress and the further organs may involve in such cases. So when the patient was admitted in ICU, we assessed the patient in the ABCD approach. Initially, what we did, we assessed the airway. The airway was breathing to this patient. The breathing was fine. Bilateral air entry was present. There was no foreign sounds. He is breathing at the rate of 20 per minute, maintaining a saturation of 98% on room air.
No foreign sound.
So in foreign sounds, say rails, crepitations, and rock cry. So there was no foreign sounds were heard. Talking about the circulation, he was maintaining a blood pressure of 110 by 68 millimeter of mercury with a map of 65 millimeters of mercury. His capillary filling time was less than 3 seconds. Yes, sir.
How do you measure the BP in this when the skin is so extensively denuded?
Sir,
Do you do an invasive monitoring?
Sir, in such cases, when the skin is so much denuded, we use invasive arterial lines. We do measures blood pressure by the invasive blood pressure monitoring, because we can't use a blood pressure cuff in such patient, because the further the shear than the friction will cause the further the skin damage. Yeah. So we did use the invasive arterial line in this patient, though I didn't mention over here. Talking about the disability, the patient was alert, he was oriented to time, place, and person. After exposing the patient, there was a macular purpuric lesions was there involving the entire body, and the body surface area which was involved is more than 90%, which we calculated by the rule of 9, which we are doing in the burns patient also. So these were we did a biochemical investigation. These patients, on the day 1, we did an extensive investigation in such patients, though we didn't found any abnormality apart from the platelet count was 1,28,000. So what will be our treatment objective in such cases? Our treatment objective mainly is the supportive. Supportive care is the cornerstone in such cases. We focus mainly on the wound care, fluid and electrolyte management, along with temperature management, pain management, and the prevention of infections. Now, talking about the wound care, we followed the conservative approach. We didn't go to the surgical approach. We did a paraffin gauze dressing in this patient. Now, talking about the fluid and electrolyte management, these patients, they required a lot of fluid initially. Because of the evaporative losses, we did resuscitate these patients just like a burns patient. But these patients, in the burns patients, the fluid requirement is quite high. It is just 50% what is required in the burns patient as compared to the burns patient. So in this patient, we resuscitated him with lingual lactate, say 2 ml per kg per percent of the body surface area, which came down to, initially in the 24 hours, it came down, what we calculated was approximately 10.8 liters. So we resuscitated him with that fluids. Now, talking about the temperature management, we need to maintain a particular room temperature in such cases. We maintain the temperature of 28 to 32 degrees Celsius. It was done to prevent the hypothermia and to prevent the excess caloric requirements, which may be because of the epidermal loss. Now, talking about the nutrition is very important. point in this case, in these cases, because these patients, they'll end up in a very catabolic state. The calorie requirement and protein requirement is very high. This patient was approximately 60 kg weight, what we calculated by the predicted body weight formula. So the targeted calorie requirement in this case was 1800 kilocalories per day, and the protein requirement was 90 grams per day.
How did you administer these calories? We saw the pictures.
Yes, sir.
Anyway, you could place a rice tube in this patient, and you want to give this calories orally. Right?
So we asked the dietitian to make a diet chart, high protein diet and for the high calorie.
How did you deliver it to the patient?
So the feed what is prepared is the isodense.
He was swallowing orally?
Yes sir, yes sir. He was.
So glucose was probably spared.
So liquid diet was initially administered. We were giving the isodense kilocalories. Whatever the feed was prepared, it was 1 kilocalorie per ml. So it was given by the oral way only. For the pain management, we assess the pain by the pain phase scale. Whenever the patient feels pain because of the air currents or during the dressing, we manage it with the IV fentanyl or tramadol. We avoided NSAIDs in such case because already it was NSAID ensues. Now, prevention of infection, it is one of the most important things. These patients, they succumb to because of this secondary infection, nosocomial infections, which they acquire from the hospital setting itself. So the cornerstone will be sterile handling along with the barrier nursing. For skin antisepsis, chlorhexidine 2% weight by volume was used. Whenever the mucosa is involved, we did use betadine in such cases because it is slightly burning sensation may feel by the chlorhexidine. Now talking about the after a few days, on the day 4th, the patient had a fever spike of 101 degree Fahrenheit. He had a leukopenia along with thrombocytopenia. Now a patient is spiking a new fever. Whenever the patient spikes a new fever, we always did a sepsis screening. In that we did send an inflammatory marker, which is a procalcitonin. Procalcitonin was found to be 6.15 nanogram per ml. We did send a paired blood cultures. We started him on antibiotics for the very first time. He was started on beta-lactam with beta-lactam inhibitors. In this case, piperacillin tazobactam 4.5 gram IV-8RD was started. Now, due to the limited improvement of the dermis and with the steroids and the cyclosporin, after conducting an MDT, multidisciplinary team meeting, it was decided to do a therapeutic plasma exchange. So, I will hand over to Dr. Garima.
Good morning, Emeritus Chairperson, sir, respected faculty members, dear colleagues, and my dear juniors. Myself, Dr. Garima. I have recently joined this prestigious institute after completing my specialization in apheresis and blood component therapy. Before hopping upon the case, I would like to open a confusing yet a basic question to the House. What do you mean by plasmapheresis and therapeutic plasma exchange? Is there any difference between these two terminologies? Anyone? Yes, there is major difference between these two terminologies. Plasmapheresis is a type of donor apheresis which is performed in a healthy donor. Example, very common example, collecting convalescent plasma to treat the severe COVID-19 infection. And on the other hand, therapeutic plasma exchange, that is plasma exchange, is performed on critically ill patients itself, as in our case. Why therapeutic plasma exchange? As we have already discussed, we need to remove the drug metabolites, the antibodies and the immune complexes, the cytokines which are formed in this case.
Can I interrupt for a minute?
Yes,
Drug metabolites still being around 7 days after ingestion of the drug is better.
They were in the blood, in the plasma. That's why we considered
7 days after ingestion.
Sir, actually,
It came to you very late. No?
yes,
So
sir.
that could not be a
Main reason,
rationale.
the cytokines and the immune complexes which were formed because of that. That was the main reason.
That's your number one reason.
Yes. So this was the table summarizing the basic investigations and procedural details for the each cycle of therapeutic plasma exchange. After 7 cycles of plasma exchange, the patient improved clinically. pain was reduced. There was no new skin and ocular lesion seen. Also, there was evidence of skin healing. These are few.
Dr. Garima, how do you monitor the efficacy of plasma exchange? What are your targets while doing it?
So
Is there a
usually,
blood biomarker you are looking at, like say interleukin levels? How do you know that you are doing the right job?
so usually it depends on the case, every case basis. What is the diagnosis? What are the investigations available? Like in neurological cases, which are very common for plasma, considered very common for plasma exchange. In that, we see the antibodies decreasing down. In this patient, there is no test available to see this in India presently. At our institute, we don't have. So there is P450 marker available in US and other specialized centers. We don't have it here. So it is typically on the clinical basis and the
How
clinical
can you say
improvement.
that there are no markers like you could have done the IL-6,
Tumor necrosis factors and tumor necrosis factor alpha and interferon gamma can be done, but this was not done in this case.
So what test you were thinking that could have been done in US and not in India?
So the P450 marker levels are done in other countries, which is not done in India. There are very few specialized centers doing this. These are few publications suggesting plasma exchange in toxic epidermal necrolysis as a rare treatment modality. This is a table illustrating various other indications of apheresis in dermatology. Thank you. Now I would like to invite Dr. Devyansh to further discuss this.
During this whole course, the plasma exchange was being done in the ICU. So patient stayed with us throughout the admission. On the day 7 and day 8, he again had a persistent fever. We did a complete blood count on that. The white cell count was 21,000 with a neutrophil predominance. 88% neutrophil was found. So to cover the Pseudomonas, we added amikacin. To cover the methicillin-resistant Staph aureus, we added him on linezolid, considering there might be a skin or soft tissue infection might be there. But patient responded very transiently. Now again for the day 10 and 11, patient still had a persistent fever, but the white blood cell count came down to 4,600. Now the blood culture reports came to us. It showed the growth of carbapenem-resistant Acinetobacter baumannii. Now we started him on meropenem polymyxin. Though in the report it was shown that it is sensitive to cefoperazone sulbactam also, but if patient is having a carbapenem-resistant Acinetobacter baumannii, it has been reported in the various trials that the mortality is way better if we give a combination of meropenem along with polymyxin B. Now I'm jumping direct to the day 20 because between the day 10 to day 20 the plasma exchange was being done on a daily or alternate day basis. Yes, sir.
I'd like to ask you an uncomfortable question.
Sure, sir.
Was this a hospital-acquired infection or did the patient come with this?
So this is a hospital-acquired infection. These bugs they found usually in the healthcare setting only because this is an MDR gram-negative bacilli and our local antibiogram they show the predominance of the Klebsiella followed by Acinetobacter baumannii. So he acquired a bloodstream infection and it was both in the both sides on the paired blood cultures. The culture report was same and the drug sensitivity pattern was also same in this case. So. So he was completed around 5 sessions of plasma exchange. On the day 20, he again had a persistent fever of 103 Fahrenheit. Now his labs were deranged throughout. His hemoglobin dropped to 8.9 grams per DL. Platelet count was 40,000. Prothrombin time and iron was deranged. APT was quite high, 51 seconds. D-dimer was high. Lactates was 8 millimole per liter. So we thought this may be because of the sepsis only. Now the patient is maybe going towards the shock. So we did again send a paired blood culture whenever a new spike of fever is there, whenever the signs of infection is there, we always send a paired cultures along with the appropriately tissue cultures if required. So we continued with the meropenem polymyxin B because we already had a report with the carbapenem-resistant Acinetobacter baumannii. One single donor platelet was transfused as it was required for the therapeutic plasma exchange. Now on day 22, the patient had a CNS disturbances. Patient was drowsy, had altered sensorium, he had a bradycardia, he was hypotensive. His blood pressure dropped down to 90/40. He had a labor bleeding with a respiratory rate of 40 per minute. We did a blood gas which is showing high anion gap metabolic acidosis with respiratory acidosis. So we decided to intubate and ventilate this patient. We intubated and ventilated with the lung protective ventilation as per the ARSNet protocol. We started with the fluid resuscitation because now the patient is again in the shock. We followed a goal-directed therapy along with the advanced hemodynamic monitoring what we have in our ICU setups. We guided the fluid with the pulse pressure variation. Norepinephrine was started with the 0.5 max per kg per minute, and we continued with the same antibiotics as we already had the culture reports in our hand. But still, despite all these efforts, the shock was worsening, the vasopressor requirement went up, he went to the AKI stage 3, ABG now is showing high anion gap metabolic acidosis with the raised lactates. We didn't focus echo to look whether we can give more fluids, whether the patient is still fluid responsive, but echo was showing global LV hypokinesia, ejection fraction was 35 to 40%, which might be because of the stress cardiomyopathy. So we decided to initiate him on continuous venous hemodiafiltration, which is a modality of CRRT. But meanwhile, when we were arranging all this, patient had a cardiac arrest. We tried to revive him, but we were very unfortunate, but we were not able to revive him. So he succumbed because of the toxic epidermal necrolysis, leading to the bloodstream infection and shock. So that's all.
Although this is not the right forum to discuss that, but I think we need to relook into our infection control policy and mechanism, especially in critical areas and critically ill patients. I would stop at that. Maybe we need to look into that at some stage, at some other.
With such a exposure of the skin all over, whether it is even the patient was at home, any infection could have taken place.
Home is all right, but it should not happen in the hospital.
Because almost 90% skin was bleed off, which is the most important protective layer.
I don't think I will go into the details, but I think
some effort should be made to try to prevent that.
How much is the mortality in the case of toxic epidermal necrosis in US or maybe European studies that you have?
We have 25 to 30%. And in this case, especially, it was 62%, according to school data.
What about the Western centers, Western data?
Because the epidermal barrier function is impaired.
And what is the most common cause of death in these patients?
This patient was allergic to one drug. In such a situation, how do we know that he might not be allergic to something else?
So that is a different issue. Now we have to act right now, we have to manage the patient. And that is a part we have to deal later on, the patient service.
So just for information, supposing you want to test a drug, that is he allergic to this or not?
Yes, sir.
How
We
do we
do
test
after
it?
2 months, after the healing is done. And we do patch tests with the drug.
No, supposing he's
Yes,
here
same.
and we think he might be allergic to some other drug also.
Yes, we'll do patch testing. Patch testing is a method where we place patch of the drug suspected and we do it after 2 months of healing.
Dr. Manisha, the concern is that he's a critically ill patient who needs a lot of medications. Now, common drug like diclofenac, which is being widely used, has caused this life's devastating illness. So, is he vulnerable to any other infection, a drug which is going to be needed for this illness? We can't wait 2 months for recovery and then
Yes, sir,
talk about the
but
future.
there are specific guidelines. The most common culprit were NSAIDs, so we are permitting them. And if we want to, we are strictly following the guidelines which are for them. And the antibiotics which have
And I mean, once a severe immunologic reaction like this has happened, can any other drug also trigger a similar reaction in the same patient?
with the same chemical composition.
Some other group is unlikely.
Yes.
adding to his question, is there any subset of population prone to for drug injury? What is that population?
There are different types of HLAs, which are like for common we have allopurinol, we have. So we have to test the HLA screening.
Which is not possible.
So in this case, we also tested for the HLA, and patient was having HLA-A2. That was one of the another reason for the susceptibility for a specific patient. And carbamazepine and these 15O2 in most of the center, they are doing HLA testing before prescribing carbamazepine, because carbamazepine is one of the most important culprit for the Stephen Johnson and TAM. And in this case, as a part of this is a very good case, we did HLA testing and we found this patient was HLA-O2 positive, which again suggests the same.
So despite all the efforts put up by various departments, unfortunately the patient succumbed to cardiac arrest. But here are some of the cases in which we were able to give timely treatment and treat the patient successfully. The first case was of a 24-year-old male who presented with fluid-filled lesions, oral ulceration and fever on and off since the last 2 days. Now in this patient, the body surface area involvement was also 90%. He was a known case of epilepsy since 2016. The score 10 was calculated, it was 2 in this case. So in picture, sir, basically I'll come to that, but sir, the offending drug was phenytoin. The patient was taking valproate for epilepsy since 2016, but recently he was switched, like 10 days before the onset, 8 to 10 days, he was switched to phenytoin, which was the culprit drug in this case, which is very high risk drug also in literature. So in picture A, we can appreciate the presence of multiple clear fluid-filled bullous lesions over the extensor surface of the forearm with underlying dusky erythema. In picture B, we can appreciate multiple dusky erythematous macular lesions which are present over bilateral lower limbs. And peeling of skin in sheets can be appreciated on the back in picture C. So this is the before and after this case. The culprit drug was phenytoin. The next case was of a 29-year-old female who presented with extensive desquamation of the skin, painful oral and perineal erosion since the last 3 days, and had body pain, for which she took diclofenac. The score 10 in this case was 2. Here we can see that in image A, we can see that there is desquamation of the skin over the erythematous base. There are multiple clear fluid-filled bullous lesions present over the abdomen, which can be seen in image B, and multiple confluent dusky erythematous lesions, which can be seen in image C. Here are the before and after pictures of the same patient. The case 3 was of an 82-year-old male who presented with areas of peeling of skin in sheets. Here we can appreciate that with underlying erythema. There was a history of multiple fluid-filled bullous lesions present over the body 4 to 5 days back. He had diarrhea 7 days back. He took norfloxacin for that, and the score 10 of this patient was 3. So in these pictures, we can appreciate the peeling of the skin in the form of sheets over the back, buttocks and the lower limbs bilaterally. These are the before and after pictures of the same patient. Thank you so much. Now I would like to invite Dr. Kiran Kumawat for the review of literature.
All these cases that you presented were confirmed diagnosis of toxic necrolysis only, and there could not have been might have, I think, maybe Stephen Johnson or something of that sort.
No, because the surface area involvement was more than 50%.
So pathologically, there was.
Good morning, respected teachers, seniors and my dear colleagues. I will be presenting review of literature. Toxic epidermal necrolysis. It is an acute, severe, life-threatening mucocutaneous adverse reaction secondary to drugs characterized by extensive epidermal detachment, erosion of mucosa and severe multi-organ dysfunction. Talking about the etiopathogenesis, those who metabolize drugs at a decreased rate, slow acetylator genotype, genetic predisposition, have specific HLA alleles like HLA-B15S202 for carbamazepine, HLA-B58S201 for allopurinol in Han Chinese, impaired capacity to detoxify reactive intermediate drug metabolites. These all are a predisposing factors in toxic epidermal necrolysis. This table shows us drugs most commonly implicated in TEN. In sulfonamide, we have cotrimoxazole, sulfadoxine, sulfadiazine, sulfasalazine. In anticonvulsant, we have carbamazepine, barbiturates, phenytoin, lamotrigine, and falbamate. In antivirals, we have nevirapine and abacavir. In antibiotics, we have cephalosporin, fluoroquinolones, vancomycin, aminopenicillins, doxycycline, and erythromycin. In uric acid lowering agent, we have allopurinol. In antitubercular, we have thiaacetazone, rifampicin, isoniazid, and ethambutol. In NSAIDs, we have piroxicam, diclofenac, solindac, ibuprofen, ketoprofen, naproxen, valdecoxib, celecoxib, and rofecoxib. Talking about the pathogenesis of TEN, these are the 4 commonly proposed pathomechanisms in TEN. In A, the causative drug. In A, the culprit drug causes upregulation of the FAST ligand, which binds to the FAST receptor expressed on the keratinocytes, which causes activation of death receptor mediated apoptotic pathway. In B, the drug interacts with MHC class 1 expressing cells, which causes drug specific cytotoxic CD8 positive T cells to accumulate within the blister fluid, causing release of perforin and granzyme B, which kills the keratinocyte. In C, the drug-activated monocyte release in exon A1, which causes necroptosis of keratinocytes. In D, which is the most commonly accepted pathomechanism, the drug interacts with CD8 positive T cells, NK cells, and natural killer T cell, which release granulysin, which induces apoptosis of keratinocytes, which leads ultimately to the epidermal detachment.
So how does this explain the manifestation of the immune reaction limited to skin and mucosa? Does this explain that? Because NK cells, T cells, they are everywhere, so why not cardiotoxicity, why not nephrotoxicity, CNS toxicity?
Sir, it is a multi-system disorder. Basically, first the skin is the first organ which is to be involved, and gradually on, thereafter other organs are also involved due to the obviously the skin failure, acute skin failure due to loss of detachment, and also due to these reactions, due to the immunopathomechanisms.
Dr. Malhotra, let me tell you, I have seen a case, good friend, medical doctor. He had an acute renal shutdown following a diagnostic manifestation. So the immune reaction can take place anywhere in the body, in any organ. He was on dialysis for a few days, but luckily he is in.
Thank you, sir. This is a systematic review which shows the major causative drugs of TEN to be antimicrobials, followed by anti-epileptics, followed by non-steroidal anti-inflammatory drugs, which constitute 15.93% of all cases of TEN. Talking about the specific treatment in TEN, various journals have mentioned early treatment with corticosteroids like dexamethasone recommended in a dose of 8 to 16 mg per day. Literature also mentions a boosting effect of cyclosporin on corticosteroids by aiding quick tapering of corticosteroids and is given in a dose of 3 to 5 mg per kg body weight. We have case reports where 3 to 8 cycles of therapeutic plasma exchange had a beneficial effect in treatment of TEN, and its role has already been discussed by immunohematology and blood transfusion team. So the purpose of presentation of this case series is that skin is usually the first organ to show the sign of drug reaction. Therefore, early recognition and prompt referral should be done to a dermatologist. In our case, the patient came to our hospital 7 days late after the onset of illness. Secondly, TEN is a complex, severe, rapidly progressive and life-threatening drug reaction. Therefore, timely admission and prompt management is the most important factor in predicting the outcome, which was present in 3 of our cases who had a favorable outcome. Number 3, there should be judicious use of drugs and proper documentation should be done of the culprit drug for the literature as well as to counsel the patient to avoid future catastrophes. And last but not the least, owing to the systemic nature of the disease, a multidisciplinary approach is very helpful in the management of these patients. We are thankful and thank you for your kind attention.